this time, I'd like to pass the ball over to Wendy Sauer of Biomodels. Welcome, Wendy.
Thank you, Elizabeth, for the introduction. Good morning, everybody. As Elizabeth said, my name is Wendy Sauer, and on behalf of the Biomodels team, we want to thank everyone for taking the time to attend the webinar today. As time is limited to cover a substantial amount of material, I will jump right in. To start, Biomodels is a preclinical contract research organization located in Watertown, Massachusetts. We were founded in 1997 out of the Brigham and Women's Hospital with a core focus of developing highly translational preclinical models of human diseases and conditions. Our team of scientists take a collaborative approach while working with clients to ensure the process of transitioning drugs, biologics, or medical devices from a concept into patients is a streamlined and well-thought process. I want to share a statistic that we are extremely proud of. Since founded in 1997, we have facilitated 28 compounds into patients. Our therapeutic expertise resides in oncology, inflammation, cardiovascular, metabolism, neurology and psychiatric disorders, fibrosis, and, as we will be speaking of today, cancer supportive care. I will now like to introduce your speakers. First, Stephen Sonis, our Chief Scientific Officer and Biomodels co-founder. Next will be Gregory Ling, Director of Research. Following, Maria Mancini, Principal Investigator and provides direct oversight to our oncology program. And finally, John Zombeck, Principal Investigator and provides direct oversight to our neurology and psychiatric disorders program.
Thanks, Wendy. My name is Steve Sonis, and I just wanted to thank everybody for joining us this morning. I'd like to do just a few introductory remarks. As the slide indicates, we're going to talk about two types of toxicities, those that are tissue-based, so the mucositis, proctitis, and dermatitis, and one that's systemic. I'd like to start off by just talking a little bit, giving you some background about supportive care in general. I think we can all agree that supportive care is a moving target, and there are really three elements that drive that phenomenon. The first is that oncology and oncology therapy, as you know, is a very robust and fast-developing area, and with every new toxicity, with every new therapy there are new toxicities. Just to put this in context, for last year, for 2012, there were 11 new drugs that targeted tumors, so oncologic drugs that were introduced, and with those came new toxicities. The second thing that I wanted to mention is that it's very unusual, as you probably know, for cancer patients to get a single agent. Most treatments now combine therapies, and there are new regimens evolving all of the time, and with them come multiple toxicities. And then finally, as the population ages, the risk of cancer goes up. Just to frame that, the risk of developing cancer if you are 40 to 59 is about a third or less than a third than if you're 70 or more. And as patients get older, they have a number of comorbidities that put them at risk and modify how they respond to drugs, and so have a wider range and more significant toxicities that follow. I think there are a number of points just in general that are important to keep in mind as we talk about regimen-related toxicities. The first is that toxicities are not simply the byproduct of nonspecific clonogenic cell death. As you remember, the thinking in the past used to be that if you gave a patient radiation or chemotherapy, the agent didn't differentiate between rapidly dividing normal cells and rapidly dividing tumor cells. And so the hypothesis was that there was simply a clonogenic cell death, especially the area of tissue-based toxicities, is the major driver. We know that that's no longer the case, and as you'll hear in a minute, we understand that the biology is much more complex. Secondly, as we'll talk about in a second, toxicities don't occur as isolated events. It's very unusual for a patient to only develop one toxicity. Rather, they develop clusters of toxicities, and what drives those clusters is common biology. Because of the understanding of the biology, we're now able to understand that toxicity risk is multifactorial it's predictable and it's quantifiable. And as things move forward, the way that translates into patients is an ability to apply personalized medicine to dealing with toxicities. And then the final point that is really critical in dealing with this is the ability to differentiate and understand that normal cells don't respond in the same way necessarily to either radiation or chemotherapy as do tumor cells. And that gives us a therapeutic window to deal with the prevention or mitigation of toxicities without modifying tumor kill, which is obviously something that we don't want to happen. This just gives you an example of the robustness of the biology behind some of the tissue-based toxicities. This is just a simple list of a number of the canonical pathways that have been identified that are drivers of tissue-based toxicities. From a drug development standpoint, the beauty of this is that each one of these bullet points provides, in theory, a potential therapeutic target for attenuating or preventing the toxicity of interest. As I mentioned, toxicities don't occur individually. They occur as clusters, and this figure just simply gives you an idea of the interrelated map, if you think of it almost like an airline route map of how the toxicities interact. The therapeutic implications of this are significant because if one has common biology for one toxicity and another, the therapeutic intervention for one is likely to have a favorable effect on another. And so it increases the robustness and the halo effect, potentially, of a toxicity intervention. Finally, I just wanted to talk about 4 elements that make a robust clinical model as we try to go to the clinic. And as Wendy mentioned, we're committed to translational research from getting concept to patients. First, the model must replicate the clinical condition. And to that end, the endpoints that are used in the model need to be pretty seamless in terms of how they translate into clinical trials. The underlying biology should be the same in the animals as in humans, and to that end, we've done a number of studies in which we've compared gene expression in the animal models with gene expression in patients to show that they're the same. And finally, the model must be cost-effective and provide actionable information as we move into the clinic. And with that, I'd like to introduce my colleague, Greg Ling, who's going to talk about the first 2 tissue-based toxicities, mucositis and proctitis.
Thank you, Dr. Sonis, for the introduction. So today I'm going to talk a little bit about 2 of the tissue-based toxicities associated with radiation and chemotherapy. And my colleague, Maria, will finish up with the third. So to start, I'm going to discuss oral mucositis. And to give a little background on the clinical information from this, mucositis is a common and painful dose-limiting toxicity associated with drug and radiation therapy for cancer. Mucositis is characterized by the breakdown of the oral mucosa that results in the formation of ulcerative lesions. And you can see on the right-hand side of this page here a couple of patient images that are presented with oral mucositis. In granulocytopenic patients, these lesions are often frequent portals of entry for indigenous oral bacteria that can lead to sepsis or bacteremia. Interestingly, mucositis is a fairly common occurrence and occurs in approximately 40% of patients that receive antineoplastic therapy for oncology indications. With 1.4 million new cases of cancer annually in the U.S., this results in about 560,000 patients that will develop mucositis yearly. With that, the duration of mucositis varies quite dramatically depending on the regimen, ranging anywhere from 2 to 10 or more weeks. The 2-week cycles are pretty typical of a chemotherapy-related injury, while the 10 or more week cycles of mucositis are related with concomitant therapy of both chemotherapy and radiation. Interestingly, patients that receive cycle chemotherapy can actually develop mucositis during each cycle. To give a little understanding of the healthcare impact of mucositis, basically what this results in is an increased unplanned office visits and emergency room visits, increased rates of hospital admissions for fluid support, pain control, or infection management. And as we mentioned earlier, the pain associated with mucositis is actually quite severe and typically results in opiate or morphine-level pain management paradigms. It can also result in interventional therapy, such as gastrostomy. Again, due to the lesions that occur throughout the mouth, patients have a really hard time eating, and G-tubes can be required. The market size for mucositis is actually fairly large, and the incremental cost associated with different type of malignancies varies. Patients presenting with head and neck or lung cancer, the incremental cost for mucositis is approximately $18,000 per patient. While those people undergoing transplants, the incremental cost for mucositis can be upwards of $40,000 per patient. Taken in total, the mucositis market is about $1.5 billion per year. With that, the current treatment strategies for mucositis are actually pretty limited and primarily focus on supportive care and analgesia. However, there are some improved mechanistic-based approaches, such as capivance or palifermin, which is KGF, and that's approved in the U.S. for the transplant population. However, the transplant population only accounts for about 4% of those patients presenting with mucositis. Another compound that's used, at least in Europe, is benzitamine, and this is simply a topical anesthetic with some NSAID properties. Additionally, some off-label use of amifostine has occurred in the U.S. Amifostine is a thiol, or free radical scavenger, that also has some anti-inflammatory properties. Most of the focus recently has been on medical devices. So for mucositis, these medical devices will actually support the barrier function, basically keeping the mucosa functionally intact and thus limiting the amount of pain that the patient can experience. Some of these that have been approved in the U.S. are MuGuard, Captisol, Gelclair, and Episil. As Dr. Sonis mentioned, the pathobiology of these epithelial toxicities are all quite similar and are not simply a result of clonogenic cell death. But instead, from this rather complicated figure, you can see that radiation induction or chemotherapy induction can result in the generation of reactive oxygen species, lipid peroxidation products, activation of pathways such as NF-kappa B and TGF-beta, and downstream pro-inflammatory cytokine signaling. All of these provide actionable targets for drug therapies. So when we talk about the drug development process for oral mucositis, the real goal of new therapies is to maintain the mucosal integrity of the oral mucosa. As we know, disruption of this barrier increases the risk for systemic infection and results in these very painful and potentially dose-limiting ulcerative lesions. However, since there's been a limited clinical success to date, there's still a tremendous need for effective therapies. While the current research profile of mucositis is increasing, that has resulted in a pretty robust pipeline of new therapies that are aimed to prevent, accelerate the healing, or provide relief from the pain associated with oral mucositis. Interestingly, most of these are mechanistic-based approaches as opposed to the device approaches that we discussed in the previous slides. As Dr. Sonis also mentioned, mucositis is one of those areas where we always are searching for the perfect animal model. And just to kind of drive home this point once again, the model must really replicate the clinical condition. The model must be translatable. The underlying biology needs to be the same. And the model must provide cost-effective and actionable information. Importantly, for models of epithelial toxicities, it is important that the changes to the epithelium should be clinically and visually identifiable, and they need to follow in its course, appearance, resolution, and dose response to systematic toxic therapies. So ultimately, the endpoints that we are looking for in these models replicate the clinical condition and symptoms. At BioModels, we've developed a number of animal models of mucositis. These models range from both acute and fractionated radiation-induced models in hamsters, a combination of chemotherapy and radiation in hamsters, as well as both acute radiation and chemotherapy-induced models in mice and rats. Interestingly, these models present very similar to that of ulcerative mucositis in patients. You can see that there's a very discrete effect between normal mucosa and ulcerative mucosa. The duration of disease in these models can range anywhere from a couple weeks to several weeks, depending on the induction paradigms. And one of the most important things about mucositis as an indication is that drugs can be administered topically or systemically. The goal of the topical administration is to limit the systemic availability of compounds that may have some adverse effects when given systemically. One of the most common models that have been used for mucositis research are the hamster models. The hamster models provide an advantage of having an isolated cheek pouch that we can focus the irradiation and visually assess the mucositis severity. This model can be induced either with a fractionated dose of radiation occurring on a 4-day on, 2-day off, 4-day on cycle, or with an acute higher dose of radiation of 40 gray. While the fractionated models more closely replicate the clinical treatment paradigm, the acute models provide a really great tool to screen compounds in a short and time-effective manner. The duration of these studies can last anywhere from 4 to 5 weeks depending on the induction paradigm. And as we mentioned, the endpoints are primarily mucositis severity, as scored visually based on the scoring scale that you can see below here. Ultimately, what we are looking for when we look at compounds for the treatment of mucositis are compounds that inhibit ulceration or decrease the severity or duration of ulceration. And that's really the defining point of any compound or any therapy for mucositis. If we look in the figures presented on this table, we can see on the left-hand side of the page the typical progression of acute radiation mucositis. And this is data from the hamster model, and is basically a meta-analysis of a number of studies that we've conducted. If you can see here, disease severity peaks between days 14 and 20, and approximately a score of 3. The score of 3 in the mucositis scoring paradigm basically results in an ulceration. With this, the disease severity is such that we are able to achieve statistically significant improvement as well as negative impacts on disease severity. If we look at the table on the right-hand side of the page, this is data that was actually conducted from a study with Actogenics. Actogenics this study looks at the extent of ulceration or the duration of ulceration. And basically this is scored by the percent of the number of days that the animal presents with ulcerative mucositis. In a control animal, the animals present with almost 50% of the study duration with ulcerative disease. The compounds that they used in this paradigm have reduced that from 50 to down near 25 to 30% of the days of ulceration, which we focus as a clinically significant result. Interestingly, Actogenics has also published some phase 1b data from a clinical trial where the results are virtually identical to this result, thus showing the translatability and predictability of the hamster models. To switch gears a little bit, now I'm going to talk about radiation-induced proctitis. Radiation-induced proctitis is a common complication associated with radiation therapy that is directed to the abdomen or pelvis for the treatment of colon/rectal cancers, prostate cancers, or cervical malignancies. Proctitis is also very common and occurs in up to 75% of patients that receive targeted radiation therapy for these indications, and can result in approximately 400,000 new cases annually. Acute proctitis symptoms usually present within 2 weeks of the start of therapy and can last for about 3 months. However, there's also a delayed or late proctitis form where these proctitis symptoms can occur and continue on for decades. The major symptoms of proctitis include rectal bleeding, diarrhea or discharge of mucus, ultimately fibrosis, ischemia, and potentially even necrosis of the bowel tissue that may require surgical intervention. Typically, diagnosis is done by colonoscopy to basically exclude the possibility of any underlying pathologies such as Crohn's or ulcerative colitis. On the right-hand side of the page here, you can see some endoscopy images from patients that have presented with varying levels of radiation-induced proctitis. So similar to the mucositis model, there's a relatively defined path for radiation-induced proctitis drug development. Interestingly, the treatment strategies that are currently available are very limited and have been primarily adapted from those used in therapies for IBD, such as 5-ASA or methylamine, steroids, sulcrafate, and even metronidazole. Additionally, some therapies have been taken to control bleeding or the chronic bleeding that occurs in more long-standing cases of proctitis, such as argon plasma coagulation. As I mentioned, there's still a very large unmet clinical need for therapies that focus on proctitis. And with that, there's also a very limited pipeline of novel therapies because this is an area that has really gone unchallenged in the last few years. As we discussed earlier, the mechanisms for proctitis and all epithelial toxicities are very similar, such as ROS generation, lipid peroxidation, NRF2 activation, NF-kappa B, etc. Ultimately, what this does is it applies these similar mechanisms of action across a number of indications. Basically, this results in opportunities for drugs in a variety of indications using the same targets. Additionally, proctitis presents with some unique vascular changes that also provide additional targets for intervention. So in order to aid in the drug development process, we've developed a few different models of radiation-induced proctitis here at Biomodels. If we look here at the top, we have both acute and radiation-induced proctitis models, and primarily done in rats. We've done this in both fractionated radiation paradigms and acute radiation paradigms. We can see from this figure on the left here that the proctitis severity that we can induce, depending on the radiation dose, ranges anywhere from mild to more severe proctitis. In the acute setting, proctitis is induced on a much shorter paradigm, resulting in peak disease about 7 days post-radiation, whereas in the chronic paradigms or the fractionated paradigms, disease peaks within about 2 weeks and continues out for up to a month. And this data is better represented here in the figure in the middle, where we can see the dose response from low to high doses of radiation in the fractionated setting, as well as the radiation the acute radiation setting on the left-hand side with the much shorter duration. As you can see from these images, we use video endoscopy as a primary endpoint for all of our proctitis models. This technology developed out of the IBD models that we conducted biomodels and has provided a very clinically translatable endpoint in terms of disease severity that's monitored sequentially in life, and also results in images that are very similar to the human condition. You can see that the ulcerative lesions that occur in the human in radiation proctitis are very similar in appearance to those that occur in the rodent. With that, I'm going to transition this presentation over to Dr. Mancini, who will speak about radiation-induced dermatitis.
Thank you, Greg. So today I'm going to talk with you about a cancer regimen-related toxicity known as radiation dermatitis. I will give some background on the disease and address the unmet clinical need for development of therapeutics in this area, and then describe our animal model and how it can be a useful tool for testing potential interventions. So to begin, radiation dermatitis is defined as injury to the skin as a result of exposure to ionizing radiation. This is generally associated with the treatment of skin cancers as well as head and neck and breast cancers. It occurs in approximately 85% of patients receiving radiation therapy, and the severity of radiation dermatitis ranges from mild erythema to moist desquamation and ulceration of the skin. Radiation dermatitis impacts a patient's quality of life for a period of time, lasting months to years after treatment. During treatment, the symptoms may be so severe that they become dose-limiting, where a patient will not receive the necessary amount of radiation to result in sufficient tumor kill. There's also a sizable economic burden where, in addition to direct medical costs, there are secondary costs of radiation dermatitis associated with a loss in productivity resulting from a patient's inability to work and the loss of future earning potential due to a premature death. And that refers back to the previous point where I mentioned that the symptom severity can be dose-limiting. So the table here on the right side summarizes the symptoms associated with exposure to certain cumulative levels of radiation, where at lower levels of radiation, symptoms ranging from faint erythema to hyperpigmentation can last for a week or two, whereas at higher levels of radiation, desquamation of the skin and or ulceration can occur, and this can last a month or more after treatment. And in addition to these acute effects, longer-term and persistent symptoms may occur as a result of high cumulative doses of radiation, and that includes further ulceration of the skin, fibrosis, and tissue necrosis, and also vascular telangiectasias. Here's a diagrammatic representation that you've seen already today, but just as a reminder of the phases of disease progression of epithelial-based toxicities in general, but here specifically referring to radiation dermatitis. You have the initial insult of radiation or chemotherapy that results in free radicals released from the epithelium, and a subsequent inflammatory cascade, which is initiated by TGF-beta signaling pathways. This results in the recruitment of immune cells, inflammatory cells, and bacteria to the injured area, and then ultimately results in recruitment of fibroblasts and other supportive cells, which are recruited to assist in the process of re-epithelialization and ultimately healing. And the persistent symptoms I mentioned in the previous slides occur as a result of these recurring inflammatory waves that keep this process going for months to years after insult. So when looking through the scientific literature, you'll often see radiation dermatitis referred to as radiation burn. This is a misnomer. So the kind of burn one would get from radiation would be as a result of exposure to a detonated atomic bomb, as referenced in historical images from Hiroshima and Nagasaki. And yet, in spite of this, radiation dermatitis and thermal burns are treated the same way in the clinic, although they are significantly different in their pathophysiology. Specifically, radiation dermatitis has a dose-dependent clinical pattern ranging from dry desquamation to moist desquamation to necrosis. It's often associated with opiate-resistant chronic pain, and these long-term complications may persist due to these recurring inflammatory waves. Even surgical excision of the damaged tissue, damaged area followed by grafting, doesn't avoid these disease-propagating inflammatory cascades. So taken together, everything I've said here illustrates the large unmet clinical need to develop therapeutics that specifically treat the tissue damage and pain associated with radiation-induced dermatitis. So to help address this clinical need, we at BioModels developed an animal model of both acute and fractionated radiation-induced dermatitis. The acute model serves as a useful initial efficacy screening tool for novel compounds. However, in the clinic, a patient will receive radiation in several small doses, and therefore we also have a fractionated model to more closely mimic what's done in patients. So in the acute model, animals will receive a single dose of 30 gray of targeted radiation directly to the skin, whereas in the fractionated model, the mice receive targeted doses of 6, 8, or 10 gray on a 3 days on, 2 days off, 3 days on schedule. In both cases, the radiation is delivered only to the skin, and the rest of the animal is protected by lead shielding. The delivered dose is measured using thermoluminescent dosimeters, and this ensures the uniformity of radiation. And as a side note, that these TLDs are used in all of our radiation-based animal models, including those you heard about just now from Dr. Lang. Dermatitis severity in these studies is evaluated every 2 days for the duration of the study, and to do that, we use a clinically relevant scoring scale. And the scoring scale is a 5-point scale that includes a full spectrum of the disease severities, where you see here that on the lower end of the scale, you see the mild erythema pictured here, whereas on the higher end of the scale, you see severe desquamation of the tissue and, in the most severe cases, ulceration of the tissue. This scoring scale closely mimics what's seen in patients, and it's representative of those scoring scales that are used in the clinic, the CT, CAE, and RTOG scales. And when we are evaluating a study that we might run here at BioModels, we would determine that a clinically meaningful signal is achieved if a compound could reduce the symptoms of desquamation and erythema, reduce the kinetics and severity of the dermatitis, and or reduce the number of days with high scores. So to go through some of the data you might expect from each study, we have the acute radiation model where dermatitis severity scores peak around 3, and this represents approximately 50% desquamation of the tissue. The induction is fairly rapid in this model, where it peaks around day 12 and resolves fairly rapidly as well, whereas in the fractionated model over here to the right, the induction is more gradual, where it peaks 5 to 7 days later than in the acute model, and it also resolves more slowly. And the data here represent a full spectrum of the cumulative doses that are consistent with a dose response that I described in my introduction, where the severity ranges from mild to moderate. Erythema with a cumulative score, or a score of just over 1 in the 36 gray dose group, where you also have moderate desquamation, a score of 3 in the 48 cumulative gray group, and here you have more severe desquamation, where you see more than 50% of the tissue in the highest dose, the 60 gray cumulative group here. And here you see the examples of some of the in-life clinical images here to the left from the fractionated radiation animals, and at their peak disease, where you can see that clearly the dose response levels of erythema and desquamation with their corresponding scores. And in addition, we have standard histological endpoints using Mason's trichrome and hematoxylin eosin staining, where you can see the thickened epidermal layers here and overall inflammation. And in this image here, you can see the influx of immune cells to the area. It should also be pointed out that the dose response that you're seeing here in the clinical images are represented in the histology as well. So to summarize, I hope that I have shown you today that the radiation-induced dermatitis in our animal model mimics what's seen in patients and can be evaluated on a clinically based scoring scale, providing a translatable efficacy signal for potential therapies. The severity on a more cellular level is evident histologically, where you can see the inflammation of the skin and necrosis of the hair follicles, as well as the degenerated architecture in the epithelium. And finally, the histology also captures the immune response that assists in healing, but also causes those chronic issues that I mentioned several times throughout this presentation. And as I mentioned previously, there are currently no successful therapies in the clinic to treat radiation dermatitis, and therefore there is a large therapeutic opportunity in this area. An advantage to using an animal model of radiation dermatitis is the ability to use topical drug formulations to demonstrate efficacy, and this minimizes the effects that are often associated with systemic dosing. And in addition, the use of dosimetry in these models provides the ability to determine that topical formulations do not interfere with or attenuate the delivered dose of radiation to the skin or the underlying tissue. So far today, you've heard about 3 tissue-based toxicities, and equally important are those which are systemic. And my colleague, Dr. Zombeck, will be speaking next more specifically about one of those.
Thank you, Maria. Today I'm going to be talking about one of the most common complaints among cancer patients, fatigue. Now, when I talk about fatigue, I'm not referring to the general lethargy that you or I may experience throughout the day. Cancer-related fatigue is defined as a persistent feeling of tiredness and exhaustion that is independent of rest or activity and interferes with daily life. That last point's important. To give you an idea of how much fatigue impacts patients, I am showing a survey of U.S. cancer patients with fatigue. Over 1/3 of patients took additional time off work or reduced work hours, and over 1/4 of patients left work altogether. Furthermore, fatigue impacts a large percentage of cancer patients, with approximately 70% experiencing severe fatigue. However, unlike pain or nausea, there are currently no FDA-approved pharmaceuticals for fatigue, at least not yet. As awareness of fatigue has grown, so has the search for a treatment. Modafinil is currently approved for narcoleptic patients and has demonstrated some positive results in reducing fatigue in clinical studies. So as the hunt for new therapies has been aided by recent research, which has enhanced our understanding of fatigue. While the complete mechanisms are still unknown, there are a number of punitive targets. I'm showing here a modified diagram which was recently published in a chapter I wrote on fatigue for the book Pathobiologies of Cancer-Related, Regimen-Related Toxicities. Briefly, cancer treatment is known to have a number of effects. For example, chemotherapy and radiotherapy often induce anemia. Anemia is known to result in fatigue, however, is not the sole progenitor of fatigue. Patients often experience chronic fatigue even after anemia has resolved. Chemotherapy and radiation therapy to the head may inhibit neurogenesis, which is thought to play a role in learning and memory, suggesting a possible mechanism for some of the cognitive deficits associated with fatigue. Cytokines, such as IL-6, have been positively correlated with fatigue scores in clinical studies. This data is further supported in rodent studies, which have shown a mechanistic role of cytokines in generating a sickness behavior response. Cytokines are in part regulated by the hypothalamic pituitary adrenal axis, which may become dysregulated by chronic stress and treatment. Combined, all these factors may interact to stimulate fatigue. So to recap, fatigue is a widely prevalent symptom of cancer and cancer therapy, which significantly impacts quality of life and adds to the economic impact of cancer. There are currently inadequate treatment options for patients, but the understanding of the mechanisms of fatigue is growing. All these factors combined illustrates a large opportunity for drug development in this space. To help enable new compounds move from bench to bedside, Biomodels has developed a mouse model of cancer-related fatigue. When we started this project, we wanted to make sure we were creating a model which was as clinically relevant as possible. We chose to measure wheel running activity, as shown in this picture here, for a number of reasons. One, wheel running activity is a physical measure, and one of the hallmarks of fatigue is a reduction in energy and an increased need to rest. Two, mice are highly motivated to run on the wheels and will do so voluntarily. This gives us a high baseline in which to detect activity reductions and allows us to measure activity in the mouse without other further experimental manipulations. In this way, it is analogous to pedometers or actigraph watches, which have been used to measure fatigue in cancer patients. To induce fatigue, we administered 2 cycles of once-a-day doxorubicin for 3 days. We then give the animals access to running wheels and measure activity for 2 weeks. It is important to note that all the wheel running activity is following treatment. What we find is that mice treated with doxorubicin persistently run less on the wheels than control animals. On the right, I'm showing you a snapshot of 24 hours of activity from day 26. You will notice that the circadian rhythm of activity is not changed. Mice are primarily active during the dark phase, as illustrated by this black bar at the top of the graph. Additionally, both groups of animals run to near equivalent levels in the morning. However, the activity of doxorubicin-treated mice drops off significantly in the afternoon period. This is similar to cancer patients who often report their most significant fatigue in the afternoon. While this is just one day illustrating the difference, I can tell you that this phenomenon is very reliable and repeatable. If you look at the graph on the left, I'm showing you the total distance traveled each day for the entire wheel running period. You'll notice that wheel running activity is reduced in the doxorubicin group across this time period. Remember that the last doxorubicin treatment was on day 12, while activity reductions are still observed on days 29, and 28 and 30, highlighting the persistent nature of fatigue in this model. We wanted to make sure that reduction in activity was independent of other potential toxicities that may be related to doxorubicin administration. As I mentioned earlier, anemia is a possible side effect of chemotherapy. And in fact, we did observe reduced blood cell counts the few days following doxorubicin on day 15 and 1 week later on day 22. However, this difference had resolved by day 30, when wheel running activity was still significantly different between groups, showing that the activity reductions are independent of anemia. We also wanted to ensure that activity differences were not due to ataxia. To test motor coordination, we used the rotor-rod test, in which mice are placed on a rotating dowel. The time it takes for the mouse to fall off the dowel is then measured. We observed no differences in latency to fall between groups on day 30, suggesting no motor coordination deficits in doxorubicin-treated animals. As Greg and Steve mentioned earlier, a major focus for our animal models is that they are predictive of the clinical outcome. We chose modafinil as a positive control for this model because of clinical studies which have suggested efficacy. Here, I am showing you summed wheel running activity in the afternoon period. If you'll remember, that's when fatigue is the greatest between groups. Notice that while doxorubicin administration significantly reduced wheel running activity, modafinil successfully recovered wheel running activity in doxorubicin-treated mice. This illustrates our chemotherapy-induced fatigue model is sensitive to pharmacological intervention. Finally, I want to mention a couple of additional fatigue projects that I do not have time to present today. The first is a study examining potential depression-like behaviors in fatigue mice, and I will be presenting these results at the Society for Neuroscience conference in November. And additionally, in collaboration with the NIH, Biomodels has developed a model of radiation-induced fatigue, which we will be presenting at the Radiation Research Society conference in September. And with that, I will hand the microphone back to Dr. Sonis to wrap up.
Thanks, John. I hope you've had an informative morning with us. We again appreciate your being with us. There are 4 points I just wanted to wrap up with. The first is that, as I mentioned when we started, it's impossible to segregate supportive cancer care from tumor therapy. In some cases, preventing a toxicity may not be that challenging. The problem is if it also prevents the effectiveness of tumor therapy, we've really done nothing for the patient. So typically when we do studies associated with supportive care, we do companion studies in which we evaluate tumor response to the test agent. Secondly, as we discussed, the problem of regimen-related toxicities is complex biologically, which makes it interesting and also provides therapeutic targets. And it's challenging because it's moving. Everybody is concerned about diagnoses of malignancy, and so there's an enormous amount of development and research activity focused on cancer therapy. So we're always going to be playing catch-up in some ways in terms of dealing with toxicities. It's important to realize that if we effectively are able to mitigate toxicities, indirectly will help patients in terms of their ability to tolerate tumor therapy and likely enhance tumor cure. And so the third bullet really focuses on the oncologist's primary concern, and that is to effectively treat the tumor, recognizing that there are a number of toxicities that are likely to occur. On the patient side, that may be an influential factor in determining the ability to tolerate treatment, and so ultimately affect the tumor response. And then finally, going back to what we said about shared biology and toxicity clusters, in many ways, if we can think about treating toxicity syndromes rather than compartmentalized toxicities, ultimately we'll be able to have, hopefully, effective options for patients. So once again, thanks again for joining us this morning. And at this point, we'll start answering some of the questions that have been presented to us.
The first question is, what is your current opinion of the best direction forward? Development of drugs that can be administered along with current chemotherapy agents to minimize these adverse effects, or development of next-generation anti-cancer drugs with minimal side effect profiles?
So this is Steve. I'll try to answer that. I think we need to do both things in parallel. Certainly, if one looks at any of the standard anti-cancer guidelines, they're based on existing regimens, and so to ignore those, I think, would not be a reasonable course to go. I mean, the toxicities are well defined. On the other hand, if one is developing new targeted therapies, the avoidance of toxicity certainly would be a plus. What we've seen, though, is in the targeted therapies, although they may avoid some of the more conventional toxicities, they bring with them new toxicities. And I guess a good example of that would be the mTOR inhibitors, which are now approved for use for renal cell cancer, breast cancer, I think shortly for sarcoma. They avoid many of the typical toxicities that we see with conventional forms of chemotherapy that are used for breast and colorectal cancer, and yet they have with them a number of dose-limiting toxicities that, in order to expedite getting the drug to patients, need to be effectively dealt with.
I'm going to address this question to Greg. Are there other models or disease indications that follow similar mechanisms as to the models presented today?
Thanks, Wendy. There's a definite yes to that question. I think that, the number of models that we conduct, the number of models that have been conducted in the research base, there's a large number that follow very similar mechanisms of action, whether it's the fibrosis induction that we see at the conclusion of some of these disease states, or it's the inflammatory nature that drives a lot of these diseases. Pathways that have kind of or other models and their disease indications that kind of have common biology include diseases such as IBD, colitis, rheumatoid arthritis, or even diseases such as fibrosis, idiopathic pulmonary fibrosis, all of which we have really reliable and robust animal models to assess.
Thank you, Greg. Steve, I'll turn this question to you. Can you share your perspective about the predictability of rodent versus non-rodent models for such toxicities as discussed today?
So predictability of models and utility of animal models has been a discussion for a long time. And models, as you know, can be used for biological purposes to understanding mechanism of action and also to predict drug response. So one of the goals that we've done for all of our models is to try to validate not only clinically but also biologically the mechanisms that drive the models. And we've done this primarily by looking at gene expression studies. And we've done those in rodents, in the hamster, mice, and rats. The non-rodent models, I think, have not been as well studied. Certainly, the mini pig has been used for many derm studies, but I think the translatability in terms of actually comparing animal data with human data are not as robust as they are with the rodent models.
Thank you. Greg, I'll turn this question to you. In proctitis and dermatitis models, do you treat rodents for pain, or do you collect data on pain as an endpoint?
So that's an interesting question. So we do treat animals for pain in all of these models. Basically, it's based on the severity of disease. So with that, based on the severity of disease, we treat with either buprenorphine or other painkillers. So interestingly, the endpoint of pain itself is difficult to assess in many of these models. The mucositis model particularly, we've focused on the hamster model and actually have conducted von Frey analysis to determine whether or not the hamsters are experiencing pain. And interestingly, the hamsters are a very stoic animal and do not exhibit any pain behaviors regardless of the severity of mucositis. For proctitis, it's a little more difficult because of the fact that it's more of a visceral pain and a little bit harder to collect data directly. However, the dermatitis model presents a little bit easier area to assess pain. With the use of von Frey filaments, well, this isn't a typical endpoint for this model, the use of von Frey filaments to assess pain behavior in the dermatitis model would be a very straightforward endpoint to include as an additional point in the model.
So we have a question that came up relative to when is the best time for intervention. It was specifically directed at dermatitis, but actually it applies to virtually all of the models that are associated with cancer therapy. If you think back about what's going on biologically, those triggers happen immediately after patients get radiation or chemotherapy. If you look at gene expression studies, for example, shortly after you radiate a patient or radiate an animal, and we've done this in both, one sees this enormous switch being flipped in terms of gene expression. So to actually wait until the patient or the animal shows sign of tissue injury is in general waiting until the horse is out of the barn. It's much more likely that a biologically based intervention will have efficacy if it's treated prophylactically and then concurrent with therapy than if one is to wait until the tissue injury actually has occurred. And I would say that probably the same thing is true with some of the systemic toxicities as well.
Great. Thank you, Steve. We have one final question, which is, Greg, I'll direct this at you and everybody can chime in here. Can you just quickly review what the market size is for each of the indications that we've discussed today? So mucositis, dermatitis, proctitis, and the fatigue.
Yeah, I think we've done a little bit of search into this, and that we know that the mucositis market size is about $1.5 billion a year. We don't have as much of a defined number for proctitis or dermatitis or even fatigue, and I think some efforts have been made in the fatigue area to determine that exact market size. Our expectation is that radiation dermatitis and proctitis are probably very similar to that of mucositis because of the fact that it may not be as dose-limiting. However, it can be much more of a chronic disease state that patients will experience symptoms for months to years later. So the expectation is that it potentially could be even a larger market.
Right, yeah. From a drug development standpoint, a commercialization standpoint, in general, oral mucositis tends to be an acute toxicity. The goal of treatment there is to get the patient to be able to tolerate treatment and get them through treatment. But as Greg, Maria, and John note, the other three toxicities not only have an acute component, but they have a chronic component. So the dosing opportunity is likely to extend for months or years beyond active cancer therapy.
And I believe that is all the questions that we have at this time. Thank you very much.
Thanks again. Bye-bye.